All right, put this into PowerPoint so you guys have my contact information. As I mentioned before, always feel free to reach out. I know some of you actually have reached out in between um, the webinars, and feel free to hold on to my contact information if I can be of help even after the series is completed. So I think last week we discussed about how we actually, out of this 5-part series, have dedicated 2 talks to really kind of reinforce the interpretation of Hep B serology screening, and then also the serology that we check once somebody's surface antigen positive. So this is the second of those 2 talks, just in terms of kind of what's ahead. The talk next week is really going to be focused on how you then take all of this information and what additional information do you need to translate this into a management plan for your patients. And I think, this will hopefully serve as a nice kind of reinforcement to what you learned last week, and then set us up for covering what we're planning to cover next week. And then finally, the last talk is really going to be focused on um, uh, additional specific patient populations, including women who are pregnant, Delta infection, and this Hep B reactivation, potential that it's important to be very aware about how to prevent and manage. All right. So we're going to kind of build upon the case that we've had since the first module. This is our 28-year-old woman born in the United States, whose parents emigrated from Taiwan 2 years before she was born here. You're the physician, and you screen the patient for hepatitis B. The 3 tests that you check as part of screening include hepatitis B surface antigen, hepatitis B surface antibody, and hepatitis B core antibody. And you find that her surface antigen and core antibody are both positive, so you diagnose her with hepatitis B infection. So the question is kind of now what? So I think we're going to come back to this case a little bit later, kind of to reinforce what we're going to discuss here. So when we think back to what we covered as kind of screening serology 101, the very first critical step in terms of identifying people with infection is screening. And the screening tests that are often used include hepatitis B surface antigen, which again is the marker of active infection. One of the definitions of chronic Hep B infection is having that surface antigen positive for at least 6 months. The other test that is very important to check when we're screening people is hepatitis B surface antibody. And this is a marker of immunity to hepatitis B, but what it doesn't tell us by itself is if it's immunity from either vaccination or immunity from prior infection. And that's where the core antibody presence can be helpful. So this is also recommended to be checked. And this is typically a total core antibody IgG test. And if this is positive, again, 9 times out of 10, it's going to indicate previous exposure, particularly in the setting, certainly if you have surface antibody that's positive. And there are some additional interpretations which we touched on last week. Katie, you had a question, I think, in between the webinars that we can kind of touch on today. And I want to say thanks to Katie because she's actually also submitted a case for us to discuss about screening and management. And then finally, if the right circumstance kind of presents itself and there are any suspicion of more recent exposure to hepatitis B, and or your patient comes in particularly more symptomatic with like a viral prodrome or jaundice, checking the hepatitis B core IgM can be very helpful since it's a marker for acute infection. All right, and hepatitis, so once you check those as your screening test, if your Hep B surface antigen is positive, this leads us to step 2. And the serological tests that are important to check in somebody who has active Hep B infection, right, if that Hep B surface antigen is positive, includes a hepatitis B E antigen, a hepatitis B E antibody, and then finally the Hep B DNA viral load, which is checked using a PCR test, a DNA PCR test. And so these are the additional tests you would check in somebody who's surface antigen positive. Now, when we talk about management next week, certainly these tests are part of that step 2, and they're the serological Hep B tests. but they're not the only tests that we do on somebody who is diagnosed as having Hep B infection. The additional tests would include liver tests, which we, I think, touched upon a little bit last week. So knowing their ALT value, doing some type of fibrosis assessment. As I mentioned briefly last week, oftentimes this is done, used to be done using a liver biopsy, which was an invasive test, and there was always questions about when was the ideal time to think about doing it. And now we have non-invasive ways to measure that. So I think I showed you a website, the University of Washington website last week. We talked a little bit about FIB4, the OPRI test, and then FIBROSCAN, which if people are interested, I can show you a slide towards the end of the talk that we added to show you how to interpret the values from a FIBROSCAN test. So again, these are the serological tests. They're not the only tests you check. Checking those additional tests that I just mentioned help you then put together a picture and try to come up with a plan regarding treatment now versus waiting. So we talked a little bit last week about how we've updated some of the older terminology, although I will say while some of this newer terminology is used by the European groups and now some of the American Association for Study of Liver Disease groups, we still see a lot of vestiges of the old terminology being used in the literature, kind of sometimes still used even in the guidances that have been recently updated as of 2018. So it's really good to kind of know what the old terminology is, and kind of the newer terminology is meant to be a little bit more descriptive, although I'll tell you that it's not perfect. But tries to give us a better sense of where maybe somebody is and how to put that together with your management plan, which, as I mentioned, we'll kind of dive into next week. So again, the tests that we want to be mindful of from a serological standpoint include that Hep B antigen. And again, in an earlier phase of infection, the Hep B antigen will be positive, and then over time, and this time is variable, but for many people, it can be on the order of, a decade or more. People who are infected will lose E antigen and typically then develop E antibody. The other serological test is the Hep B DNA PCR viral load. And again, in the early phases when the E antigen is positive, this can be very elevated, particularly in our individuals who are born in countries where Hep B has a much higher prevalence. So in our East Asian populations, West African or Sub-Saharan African populations, among others, you might see a viral load that's very elevated. And when we say very elevated, we're typically talking about, greater than 1 million. And again, that's associated with an earlier kind of stage or phase of infection. And in that setting, you will typically have a low to normal ALT value. That's your liver and one of the liver enzyme tests. And that's what we used to kind of universally refer to as immunotolerant. The feeling was that even though you had a very high viral load, that there wasn't much actually damage or activity going on in the liver. So kind of counterintuitive, even though the viral load was very high, which, can raise a lot of alarms just by itself. We know that for a lot of people, this correlates with not much actually activity in the liver if we were to do a biopsy. And this is based on, studies that were largely done many years ago. Kind of some of the newer terms that have in some instances kind of replaced or go side by side with immune tolerant is normal or minimal hepatitis. And I think that's a more descriptive, helpful term because it tells us a little bit more than immune tolerant might. But typically it's associated with very little or no activity in the liver from inflammatory standpoint as well as fibrosis. And the other thing I'll say as we're discussing these various kind of phases, if you will, is that oftentimes we don't have everybody who fits very clearly into a box, although for a lot of patients, you'll see a similar pattern over time, particularly as you're following a patient over time. And then this is typically followed this immune tolerant or normal minimal hepatitis phase over time. And again, that time is variable. If you were to check E antigen titers, which we don't do clinically, but if you did, you might see these drop, and you might then see the development of E antibody. And during this time, the Hep B viral load might do more kind of up and down or oscillation. And so that might be a clue if you're following somebody long term where the viral load, you're seeing kind of ups and downs. They could be going into a phase where we used to call this immune clearance, and with the rise in an ALT. But, as you see with the dashed lines, it's not like 100% of the time that as the ALT come up that you're going to see the DNA come down so clearly. So, and that's why they've included the dotted lines here. So to key you into, individual kind of variations that you might see. But generally over time, that DNA level comes down. And as you do, your body goes through clearing the E antigen that is associated with this kind of transaminase response. And then you go on to develop E antibody, and things for the most part for many people can quiet down. So in the next talk, we're going to talk, when we talk about management, kind of patients in this phase might be monitored a little bit more frequently. And then patients over here are monitored to see whether or not they are recommended for treatment. Kind of in this middle phase of inactive carrier, or now what we call normal or inactive hepatitis, which I also don't like, because even while you might have somebody with kind of like a normal ALT and a low Hep B DNA, you still might have variations or outliers where you do a fibrosis assessment and they have, like stage 2 fibrosis. So I don't really love the term inactive hepatitis, but it still remains. And the old terminology was inactive carrier, which I think was particularly very confusing, because I think it kind of gives us a false sense of security that everything's okay and there's not much to worry about. And, you might find that not all of these tests are lining up to put them into a nice, neat box. And then this is typically followed over time in some people with signs of progressive fibrosis, where you might see that ALT kind of going up and down, and you might see that DNA level kind of going up and down. And these patients are felt in that E antibody phase to be at higher risk for developing progressive fibrosis, which can then take you to cirrhosis, and certainly increased risk of liver cancer in the setting of cirrhosis. But remember, Hep B is a virus that's very unique in terms of etiologies of liver disease, and that it's directly oncogenic, and you don't need to have cirrhosis to be at risk for liver cancer. So we're going to be talking next week a little bit about liver cancer screening and who to do it and what age. So another way to kind of look at this, and again, I'm really spending more time on this topic to try to just give as much clarity as possible about how do you put all these serological tests together. So again, in an earlier phase, you're E antigen positive, and then over time you lose that E antigen and develop E antibody. So then you go into an E antigen negative phase. So that's what this top box is about. And again, anywhere along the spectrum, as long as your surface antigen is positive, even if it's high, intermediate, or low, as long as that surface antigen is positive, you by definition have Hep B infection, and most likely chronic infection, as we talked about. Again, when the E antigen is positive, that's kind of associated with an earlier time of having this infection, maybe within the first 10, 15 years, or even up to 20 years. And then over time, some people lose E antigen and develop E antibody. And again, that viral load, typically when that E antigen is positive in that earlier phase of infection, you might have a normal ALT and a very elevated Hep B DNA of greater than 1 million IUs per ml. Now the conversion, some of the tests use copies per ml rather than IUs per ml, and the conversion factor is 1 to 5.4. So 1 IUs is kind of equivalent to 5.4 copies per ml. So something just to keep in mind depending on the assay you're using. And again, in an early phase, normal ALT, and this is associated with not much liver disease generally. Now, as your E antigen, you're starting to lose E antigen and this wanes, your viral load might come down, your ALT might go up, and this is again associated with that immune kind of clearance phase where you might have more activity, particularly inflammatory activity, which is why your ALT test goes up. And then over time, as you lose E antigen and develop E antibody, surface antigen, if you were to check it in titers, that's why it's reported as high, intermediate, low. Clinically, we don't typically use the titers. I will say, we were just at the liver meeting, many of us, about a week ago in Boston, and there is a lot more work looking at how we could maybe use surface antigen titers to help us predict who might go on to clear or resolve infection, but not something we're using in clinical practice yet. And then in patients who are antigen negative, certainly people who have a higher Hep B DNA and the threshold that's used in the guidances around treatment, greater than 2,000 IUs per ml, and who have an ALT elevated are at highest risk for progressive fibrosis. And so typically this is a category of people that generally, if you were to meet enough of these criteria, that we would recommend for treatment. And we're going to discuss this in the management talk kind of next week. And then what things to kind of just be on the lookout, because in terms of resolved Hep B infection, we've included a column here to the right. So certainly once you've lost surface antigen, which there is a chance of doing spontaneously, and some treatments also increase your chance of the surface antigen clearance. And that's covered next week, because we'll be talking about medications and what the rates of surface antigen clearance are. But if you were to go from positive to negative, that means you've resolved Hep B infection. You would then be E antigen negative at that point. Your viral load should be not detected, and your ALT would be normal. And you can still remain core antibody positive, because remember, that's a marker in this setting of previously being infected. And some people, even if they've lost surface antigen, may not go on to develop surface antibody and only be isolated core antibody positive. Okay, so just again, another way to look at these tests. Sometimes it's hard to fit our patients right into one of these boxes. So it's more to give you kind of a feeling of, the tests, how to put them together, kind of general interpretations if they're in a certain category, to give you a sense of, how much activity of disease we think they have. In older times, before we had good non-invasive ways to assess fibrosis, we would wait to typically around here or here to think about doing liver biopsies. And so that this kind of second column or this fourth column. And it was always kind of tricky, because not everybody always lines up into one of these columns very nicely. Sometimes your ALT might be normal, your viral load's not quite above 10 to the 7th IUs, but you're E antigen positive. That's just like one example. All right, so, and I think examples are kind of helpful. So we've kind of created some mock-up cases on the left, and then included the interpretation here on the right, general interpretation. And again, these are general interpretations. They're not the whole story, but kind of how you can, in your mind, try to fit patients into one of the quote-unquote phases. So the first case is a Korean male, 52-year-old, and this person is surface antigen positive, so by definition they have active Hep B infection. They're E antigen negative, okay? They're already E antibody positive. Their Hep B DNA is not detected, and their ALT is normal. So this is somebody who definitely still has active infection, but would be put into the normal or inactive carrier is the old term we used to use, hepatitis. So somebody who still needs monitoring, but probably doesn't have too much in the way of disease activity if we were to take a window into the liver and do a biopsy, generally speaking. All right, the next case is a 38-year-old Vietnamese male who is surface antigen positive, so they have active infection. This individual is E antigen positive, so that they are probably kind of in a earlier time point in terms of how long they've had this virus. They are E antibody negative, and their Hep B DNA is elevated, and their ALT is elevated. So this, again, if you were to look, kind of compare it to the slide before, would be somebody kind of in that chronic hepatitis, immune active infection kind of phase. And again, you can see how just if you were to look at just these terminologies, they still are imperfect, I would say, and don't tell us the whole story going on with the patient, which is why we do additional testing and put it all together to try to come up with a management plan. The third case is a Nigerian female, okay, who is 25 years of age, again, surface antigen positive, so has active infection, is E antigen positive, has a Hep B DNA, is very elevated. That's what we mean by 2 arrows, and the ALT is normal. So this is what we would kind of generally think of as in that immune tolerant phase, that early phase of having, maybe the first 10 to up to 20 years of infection. And then finally, the last kind of mock case here is a 52-year-old Taiwanese female who's surface antigen negative, so no longer has or does not have active infection. Their surface antibodies negative and their core antibodies positive and their ALT is normal. So again, this is that the 9 times out of 10 interpretation of this will be resolved infection and may not have developed or had a waning surface antibody titer. So again, these are just kind of descriptive terms. A lot of your patients might fall into one of these buckets more neatly, but not every single patient is going to be able to fall into this bucket. And I think this is where it becomes really challenging for providers, and it presents itself, to be honest, as a barrier, I think, to bigger adoption around Hep B management in practices because of how you put these serology tests together and translate it into kind of in the back of your head where this person might be. Although additional testing, including a fibrosis assessment, is really important to be more confident and goes into how we put this together into a management plan for your individual patients. So I'm going to stop here and take questions. A lot of this was kind of reviewing information from last week, and it was our kind of reinforcement of serologies, since I think this is a big barrier to providers feeling comfortable and confident around Hep B management.
So we're doing like a test. I'm giving him vaccination to see if he mounts some sort of.
I heard somebody talking and then it stopped. I don't know, Ashley, if that's what you heard too.
I did. Does anyone have any questions? You're able to unmute yourself unless you're on a phone, and I've unmuted you for you.
So that may have been Katie or Taryn or someone else.
This is Brianna.
Hi.
Hi. I'm curious because they look almost similar, but I'm not sure I understand what the difference between immune active infection versus immune tolerant.
So
because I have all the same, it looks like they have all the same markers.
On the cases?
Yeah.
Immune active is this top one here, and immune tolerant. So the difference here is the ALT and the DNA test. So if you go back, so you see.
I didn't see normal. Okay.
Yeah.
Okay.
Yeah. And again, I keep saying this over and over again, and I can't stress it enough that sometimes your patients aren't going to fit into this like nice neat box that we have created here. And so yes, in this earlier phase, your Hep B DNA will typically be very elevated in an E antigen positive patient with a normal ALT, and you will commonly see this in particularly East Asian patients, Sub-Saharan African patients who you think may have acquired this mother to child, right? Or in early childhood, where we know geographically speaking, based on kind of what I covered in the first talk, there's higher rates of acquiring this infection at the time of birth or in early childhood. It wouldn't be unusual for you to see this type of immune tolerant pattern, particularly in kind of like your young patients who are maybe immigrants from countries where this is endemic and they've had it, and you're checking them in their 20s and they're still in this immune tolerant.
Is she talking about that now? No.
Hello? Taryn, was that you? I feel like I can kind of see the names move up and I wasn't sure. Yeah.
Yeah, I think Taryn might be going on and off mute accidentally, but I'm not sure. If you have a question, please feel free to unmute yourself again. Does anyone else have any other questions?
And if audio is challenging, remember you can always type into the chat function too.
Yes, absolutely.
If you're having any issues, and just let us know. So I think wanted to stop here, and it would be great if so I'm going to show you one other thing before we talk about the case that Katie submitted. So we'll talk about this a little bit more, but you know, you've probably heard the term, or I think we've talked about this in prior tests, in prior webinars, sorry. One of the individual learners on the webinar, I think it was maybe in the first or second session, talking about kind of accessibility of FIBROSCANs, and we went into a little bit of a discussion. I can't remember if it was last week or the week before. But FIBROSCAN's kind of a non-invasive test. It's uses transient elastography to try to measure stiffness in the liver. It's a test that's being used more and more often. It was kind of really first kind of evaluated for Hep C and HIV co-infected patients. So what they did was they did biopsies along with using this technology, which it almost looks like a kind of a probe. It looks like something you would do similar to an ultrasound, but it's using shear waves or sound waves to measure how stiff the liver is. So it's a non-invasive test. It's a test you could do within minutes. I did a couple of these this morning on a couple of Hep B patients. And the score that it puts out in kilopascals, it goes from 0 to 75. And depending on the score that you get, and there's a way to interpret whether or not there's reliability in the score when you do the test to know how accurate it is, you can match it up against the etiology of liver disease. So again, initially, I think it was developed more for hepatitis C and Hep C HIV co-infection, but they've now done these studies using biopsies compared to FibroScan to really validate this as kind of a non-invasive tool to be using in practices. So while you may not have it in your practice, sometimes you might know of somebody in the area where you can send somebody. I think the context in which we discussed this were some barriers in getting people an authorization to go get it. The reimbursements, I'll tell you from our standpoint, are still very low here in New York for it. So we actually, we do it even as referrals or consultations on patients pretty frequently, even if there are insurance challenges. We don't let that hold us up. Now, the one thing to keep in mind is that this test, the score can be elevated the more inflammation there is. So for example, somebody with alcoholic liver disease, particularly alcoholic hepatitis from really recent drinking use, autoimmune hepatitis might kind of give you artificially elevated scores just from inflammation, not really related to fibrosis. So inflammation makes this liver look more stiff using this score, this test. And so we always, take a very careful alcohol history. Some people have Hep C and autoimmune hepatitis. So we're always kind of looking for making sure we're using it in the appropriate way and we know how to interpret it. But it's a really quick test. We hardly do liver biopsies because of it anymore, where we used to put a lot of people through hepatitis B somewhere along their, follow up with us through a liver biopsy, and it was always a big question of what's the optimal timing for biopsy, and then when do you repeat a biopsy to see if disease is progressing. So we don't have to do that for a lot of our patients, which patients like because non-invasive things have less risk typically. And then there's more provider kind of acceptability and referral for these type of tests since it's non-invasive. Okay, so that's my spiel on fibrosis. Did anybody have a question? If not, we can turn it over to Katie to walk us through the case, and I can bring that up. Just give me 1 second. All right, so let me do this. So I think that, so Katie, thanks again so much for sending in a case.
Yes, thank you.
I'm not sure if it's that exciting, but we can certainly talk about it.
Yeah, I would love to talk about it. And like I said, I think one of the tenets for how we learn about clinical management is kind of this case-based learning. And so the ECHO model is very much built on case-based learning. So it really depends on our learners bringing up cases so that we can talk about it. So can you see one or both of my
we can see the correct form. Would you mind maybe zooming in just a little bit more?
Okay, I actually have it pretty zoomed in.
Oh, okay, that's a little too much. Yeah, it was good where it was.
There?
Yeah.
Okay. And do you only see one page, Ashley, or two?
One page.
Just one.
Okay, so I will have to toggle back and forth to show you the other one. It's just the way the share screening is happening. It's not letting me just show everything in
Okay.
Okay, so let's start here. Katie, do you want to walk us through this case?
Sure. This is a 50-year-old co-infected patient with hepatitis B and HIV who I've been following for probably 15 years. And it's been pretty easy, or in the back of my head, his hepatitis B, because of being on HIV meds that also treat hepatitis B. So I really haven't had to make the decision about treating or not treating him. Sometimes I add on some hepatitis B tests. We always check the ALT and AST, but probably once a year we'll look at his DNA, sometimes more often. He's not super compliant in coming in for visits. I probably see him 2 or 3 times a year, but he is really good at taking his medications. And so that's always been a relief and something that doesn't cause me to worry. We talk a lot about him staying on his medications so that his hepatitis B doesn't flare. He knows how important they are for his HIV, but we also try to incorporate that they're doing more than one thing and he should continue to take them. Yeah, that's pretty simple. He is doing well. He still has the surface antigen positive, but he's converted from envelope antigen to envelope antibody, and his DNA is undetectable and his ALT has been normal.
So let me, I'm actually going to, hold on. I'm going to show the second page of what you sent over. Let's see if I can do this without, can you guys see the second page now I have up?
Yep.
Okay, great. Let me see if I can lower this and make it bigger. Is that good? All right.
Yes.
So Katie, these are the tests. So you said this patient was diagnosed in 2004. They're African male. The BMI is a little elevated at 31. Just want to make sure we go through the entire case. Diagnosed with Hep B in 2004. Is on Genvoya, Cozar, metformin, and aspirin. So was getting tenofovir, emtricitabine as part of the HIV management. And so on this page, I think what you shared with us were the more recent serologies, right, Katie?
Yes, just last month, yeah.
Okay.
Or this month.
Yeah, so 2019, November. And here what you note was this person was previously surface antigen positive, correct?
He is surface antigen positive.
Okay, oh, so sorry, did you check?
Envelope. He was previously envelope antigen positive. Oh, I thought that was one, I thought that was E antigen and antibody. I was filling it out too quickly.
Oh, okay, so it should be surface antigen positive.
Yes.
Okay,
Yep.
And E antigen positive. And
antigen positive, yes.
okay, and then you also check their Hep A status for opportunities for prevention, it looks like.
Yeah.
And they're hepatitis A antibody positive, and you also screened them for Hep C, which
Yes.
the antibody was negative, and you also did an RNA, which was negative. Delta virus was not checked. There's been a lot more kind of recent publication about who we should be screening for Delta, and I'll make sure it's actually added to talk number 5. This is, again, I think we mentioned it last week, it's a kind of by itself, it's not a virus that can exist without hepatitis B surface antigen being present. And so it's really codependent on having Hep B infection. And so there's actually been a lot more talk about who we should be testing and should we be screening everybody or just certain populations at higher risk. So we're going to cover that in the last talk as well. So that wasn't done here. And the laboratory values showed a white cell count of 5.2, a hemoglobin that's normal at 15. The platelets are in the 200s. Does a CBC by itself give us any clues from the liver standpoint?
Platelets.
Yeah, so platelets are kind of a nice surrogate marker or proxy for portal hypertension. So certainly most assays use a reference range of normal, something above 150 or so. And so if your platelets are less than 150, that in the back of your mind should kind of raise suspicion that this patient could have more advanced liver disease and may need a really careful fibrosis assessment. So the platelets can be very helpful as kind of a proxy, if you will, and it should, if it's low, trigger you to think, in a person with Hep B, could they have more advanced disease? Okay, the creatinine's a little elevated, 1.35, the glucose is 158, total protein 7.7, the albumin's 4.4, the ALT's 15, right? And we're gonna talk a little bit about what a normal ALT is next week, but that would be considered normal. And AST of 21, and the GGT looks like was in the 70s, 72, I think there, and the total bilirubin 0.3. So I think, Katie, one of the questions you had raised was, in co-infected populations, if the core antibody is isolated positive, we spent a little bit of time talking about how 9 times out of 10, generally speaking, if just the core antibody is positive when you screen somebody for hepatitis B, so the surface antigen's negative and the surface antibody's negative, this is going to be somebody who's resolved infection. And they just may have either had a surface antibody at one point that's waned or never kind of mounted enough to develop that surface antibody. So one way you could try to distinguish it, so we talked a little bit about checking additional tests. So if we want to know if that core antibody is real, you could first repeat it. You might want to repeat the tests after a certain period of time if you think somebody might be in the process of more recent Hep B infection going on to clear it. So you could repeat them in a manner of like 3 to 6 months. You could check additional tests such as the E antigen and E antibody, and if either one of those are positive, that would go along with well, certainly you would expect, if anything, the E antibody to be positive if it's cleared infection. For some reason the E antigen comes back positive, you should also check a DNA level just to make sure something funny is not going on with the surface antigen test. The person I learned a lot of learned about Hep B from used to tell me, like, hepatitis B doesn't follow any of the rules. And that was like the one thing to kind of keep in the back of your head. So sometimes these serology tests, again, don't all line up perfectly for us to put them into a box. But the question that you asked, which I thought was a really good question to share with others, was, is there a role based on what's been recommended for vaccine to see if people will develop like that surface antibody response, right? And what we said is that could be one strategy you employ by giving somebody who is core antibody isolated positive a Hep B vaccine to see if they go on to develop a surface antibody. So it would be one way to kind of distinguish somebody so let's say you do that. What are we really talking about in this scenario? So you have somebody who's core antibody isolated positive. You're thinking, what's the role of giving them a Hep B vaccine to see if they'll make a surface antibody response?
You're assuming they have a false positive. It's a false positive core.
Right. So you're really kind of you're trying to distinguish if that core antibody is false positive. And the reason to do that, particularly in a co-infected patient or somebody who also is infected with Hep C, so if they're dual infected Hep B and C, or they have already Hep C or they already have HIV, is that there's more chance for cross-reactivity in the core antibody test when you have one of those two viruses. So it could be a way that you could distinguish whether or not that core antibody is false. So then if it was a false positive, then there would be an opportunity for immunity potentially, and that would kind of be giving a therapeutic and a diagnostic option at the same time by vaccinating them. So it's a little bit, for most providers, a little bit kind of off kind of one of the core topics, but it's important to know that could be, if you're suspecting a false core antibody positive, you could vaccinate them to see if they develop surface antibody, and that would tell you, particularly in a co-infected patient with HIV or Hep C, where there is a higher rate of cross-reactivity of false positive core antibodies, how to distinguish those two. And if they do develop surface antibody, that tells you that that was a false positive.
But if it's a true core antibody, it is protective, even if they don't go on to make surface antibody.
Well, it means that they've resolved infection. So, and certainly, yes. So they can't, it's not like you can, so the one scenario where you can get it again, quote unquote, would be reactivation. So patients who are isolated core antibody positive are at risk for reactivation. That's the topic we're going to cover in the last module. So the most common scenario where that's critical is if like this patient who's core antibody isolated positive goes to get chemotherapy or goes and gets, you know, immune modulatory therapy for their rheumatoid arthritis, psoriatic arthritis, or, you know, one of the other agents that you might be using immune modulation therapy for nowadays. So,
And maybe more commonly hepatitis C treatment.
Yes, and Hep C treatment, and we're going to cover that in that 5th module too. So this concept of who's at risk, right? So outside of being particularly immunosuppressed, there isn't like a day-to-day risk, okay? But if you are going to go and then like give them immunosuppressive or immunomodulatory therapies, there's a risk that you will then develop surface antigen and reactivate your Hep B. So anybody who's core antibody positive, certainly if that's real, is at risk for that. And so it's something to keep in mind as you're caring for these patients. And if they develop another medical problem for which they might receive cytotoxic or immunosuppressive or immune modulatory therapy, they could be at risk for Hep B reactivation. And we've certainly seen that with the direct-acting antivirals for Hep C. So now it's universally recommended anybody with Hep C gets tested with Hep B core antibody as part of their Hep B screening before you treat their Hep C, because we've actually had people die from reactivation of Hep B when we're treating their Hep C because we didn't look for it. Yeah. And we're going to cover that in a little bit more detail in the last session. Katie, was there anything else you wanted to discuss as part of this case, or questions you thought of for this case, or I'll open it up to the rest of the learners as well?
I think a lot of my questions still go back to like monitoring for cancer, which you're going to speak on, when to test for Delta, and yeah, those are my 2 questions: when to test for Delta and the monitoring still.
Okay, so we're going to definitely cover that in the 5th module. So if it's okay with you, let's circle back on those 2 issues when we get there.
Sounds good.
Okay, thank you.